So as national insurance started to invent in the 1930s, they turned to hotels, saw maids were rolled into room rates, and they rolled nursing into room rates, hiding their value from plain sight, rising the term handmaiden to the physicians, and leading to our first major nursing shortage in the 1930s when many nurses walked away from the profession in protest of no longer being able to be valued and paid for their services.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management at the Naveen Jindal School of Management. Here at the University of Texas at Dallas, we bring together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare ecosystem. I'm Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management. Be sure to subscribe on Apple Podcasts, Spotify, or your favorite podcasting app to ensure you don't miss any of the future episodes. You can also join us online at businessofhealthcarepodcast.com. Nursing. The previous episode, number 36, was the National Nurses in Business Association, and episode number 46 was Connect RN, digitally connecting registered nurses. And recently, episode 109 was West Coast Nursing University. But those were just the warm-ups to today's conversation, episode 115. I'm delighted to have Rebecca Love with us today on the Business of Healthcare podcast. Rebecca is not just a nurse, but an innovator, author, and speaker. She is a LinkedIn top voice and a TED Talk, remember, Ideas Worth Spreading, about how nurses can drive healthcare innovation. Her activity bio is much too long, much longer than the time we've allowed for our podcast. So welcome, Rebecca, to the Business of Healthcare podcast.
Bob, it's an honor to be here. Thank you so much for amplifying the voice of nursing.
Well, look, I'm going to start by telling you my perspective on nursing. For the last 747 days and counting, I have been with nurses every day as they've cared for my brother. My engagement has ranged from ICU, long-term acute care, rehab, and skilled nursing facilities, from the certified nursing assistants and licensed practical nurses to the registered nurses and the nurse practitioners. I am truly amazed and blessed. So that's why I care about nursing. I've seen it and I know it, and I know you know way more about it, but I'm not just a casual person on the sideline with this. But we have a lot to cover today. And we'll get into several problem issues that need to be addressed. And we'll learn about your newly formed Commission for Nursing Reimbursement. But first, Rebecca, tell us your story on how you got started.
So, Bob, first, thank you for letting me know about what's going on with your brother, and two, for recognizing the value that nurses have been playing in your lives as he's going through this time. And for me, nursing was not something that I thought I was going to do. I had another degree in international relations. I thought I was on my way to law school. I was working on a presidential campaign, was supposed to be moving to Washington, D.C. And at that time, I had a phone call that my mom was coming in to visit me. And she flew in and we were out to dinner. I thought we were celebrating this new path I was going on. And she looked at me and she said, we're not going to support you going to law school. She said to me, we think you need to be a nurse. And I remember sitting there in that moment, and my mom had gone to nursing school late in her life. She called me when I was a freshman at college, and she was about to turn 50. And she said, I just got into nursing school. Am I too old to go? And I looked at my mom at that time, and I said, of course not, Mom. Go become a nurse. So she graduated from nursing school the year I graduated from my undergrad degree. And
Wow.
She said, since I've been practicing as a nurse, she said, what I've come to realize is that there are plenty of strong lawyers in the world. There's not enough strong nurses. And this profession needs strong leaders, and I need you to become a nurse. So I agreed to apply to one nursing school, was told there was a 2-year waiting list, but then got an acceptance letter about 3 weeks later. And if you believe in signs, I do. I thought it was a sign that I was supposed to go on and become a nurse. So to be honest, I never thought I was going to be a nurse, but that's how it happened. And I've tried to live that mission every day since entering the profession, because I saw immediately what she meant when I stepped across the bedside of the challenges the profession faced to have an equal footing with the professions in healthcare that surround it.
Well, that's interesting. So you got into the nursing field. What was the moment where you said, there's more to this than what I learned in nursing school? What was something that provoked you to say, hold on a minute, something's not right? Because what I'm sensing from learning about you is that you are more than an advocate. You are a change maker in the nursing world. What triggered you to start thinking differently?
So, Bob, it actually happened. I was teaching at a community college in Boston called Bunker Hill Community College. It was 2013. And at the same time, I was a hospice nurse practitioner. I don't know a nurse who works one job. I'm sure you've had that conversation at this point. But what happened for me was my students had graduated with me in December 2012, and a group were coming to meet with me around March 2013. And I had left seeing a patient that morning who was in hospice care, wanted to die at home, but they couldn't find a nurse to care for them. So their family was putting them into a long-term care community to live out the rest of their life. And they were devastated to leave their home. And I left that meeting feeling deflated and showed up to meet my group of students who had graduated with me. And when I arrived there, they were deflated because it had been 3 months post-graduation. And as an associate degree nurse in Boston, they could not find a job. And in 2013, I remember sitting down at my computer and turning to the internet thinking, there has to be a place that would want to connect patients with these nurses, or find a place that nurses could find jobs. And there wasn't one. And that was when I went home that night, feeling very frustrated by my day, waking up in the middle of the night, rolling over to my husband and saying, I have to create a job board for nurses. And he rolled back over and said, that's great. And I got out of bed and called my mother again at that point in time and said, Mom, I know what we have to do. We have to create a job board for nurses. And at that time, we had 3 little kids. Money was not something that we had a ton of, as most young couples don't have at that time. My dad at the time said he was not interested in giving us money. And my mom gave me her nursing retirement to start that company, Hire Nurses, in 2013. Wow. And it was all with the idea of, if I could create a place where nurses could put their profiles and find jobs that they really wanted, could we actually change? At the time, associate degree nurses were hired. There was a black hole. Nobody would respond to your resume. There was a surplus of nurses. But I kept thinking to myself, we're disempowered. So that was my first step of saying, here's a problem. Somebody needs to do something about it. I guess that somebody is me. And that's what we did. I never learned how to make money, though, Bob. I'm terrible about that side of it. You give away a lot for free as nurses. So,
well, Rebecca, is there confusion in the marketplace when you say the word nurse? I'm sure that people have different impressions of what nurses are, and I think it'd be good for our audience to really understand the level of nursing here. Can you kind of start at the bottom and work our way up? Because I'm going to try to make a point about the confusion with that.
So, I think there's different titles that go around nursing, but if I can just tell you what nurses do in general at first as a profession, is nurses are the ones who provide the care the 24 hours a day when the physician is not at the bedside, those 10 minutes a day. They're the ones who deliver the life-saving interventions that keep patients alive, that nothing else to date can replace. No technology, no service, no other profession has ever been able to replace the nurse. Nurses keep people alive. They heal them. They care for them. They provide the empathy and the hope and the assistance at people's darkest moments in time. When their life hangs in the balance, nurses stand between life and death, making sure that you get to go home again. So within that scope, there are different titles. One is called a CNA, a Certified Nursing Assistant. That is a non-degreed program. It is a license that one can obtain after 6 months of training, 3 months of book training, 3 months of clinical training that is occurring in a nursing home. That's where CNAs are trained. You have an LPN, which is a licensed practical nurse, also known as an LVN, I think in Texas, vocational nurse. That is a 1-year degree nursing program, followed by associate degree nurses, referred to as an RN, a 2-year nursing degree program that is found at most community colleges, followed by a BSN, which is a 4-year nursing program. However, they sit for the same licensing exam as the associate degree nurse for the RN exam. And then you're followed by advanced degrees, something referred to as an NP, which is a master's prepared nurse practitioner, which means they can diagnose and treat and are billable services, and then following up by your doctorate level nursing as well. So those are sort of the scope of the CNA or the nursing workforce.
Okay, within that hierarchy, does the nursing community look at each other as all nurses are? Is there a hierarchy where I am, better than you, I'm different than you? The reason I bring that up, the point I wanted to try to make was that when we stop and look at physicians, you have a long white coat, you're a doctor, you might have a PA, a physician assistant, but there's not like several different categories. And does that dilute the value or perception of what nurses do within the healthcare industry with doctors and others? Is that a problem, or is that just something I'm thinking about here?
Was an argument that was made largely back in the 2000s when most of the nursing profession felt like the reason that nurses exist in this hierarchy was because we did not come out at a bachelor's degree level comparative to the large other healthcare professionals on equal grade, physical therapists, occupational therapists. MDs all had a minimum level of education at a bachelor's degree before they could go on for further education, right? That would qualify them to work in the healthcare field. So there was a large push, and based on research largely by Linda Aiken out of the University of Pennsylvania, that showed that studies that had higher amounts of BSNs or bachelor prepared nurses at the bedside led to better patient outcomes than hospitals that had a largely associate degree nursing program, LPN, or also something called diploma nurses that largely no longer exist, but were hospital trained nurses in their program. So in the 2000s, large push to force every associate degree diploma nurse to go up to the level of a bachelor's degree. And get that additional education. I think to your point, the question became largely in the scope of nursing. Did the bachelor's degree program elevate the profession to be on more equal footing with the other professionals around it? And I think one would argue that 20 years later of pushing the vast majority of nurses in hospitals specifically to become bachelor's prepared, that the hierarchical power structure has not significantly changed, nor has the conditions for the nursing workforce actually improved. In fact, one could argue that turnover is higher now than it ever was before. The average length of experience of a nurse today is down from 6 years of experience on a 12-hour shift prior to the pandemic, down to 2.7 years of experience of a nurse on a floor, the lowest in the history of nursing. 50% of all new grads leave the bedside within 2 years of practice, the largest exodus of any profession in the United States. We graduate 185,000 nursing students a year, more than any other degreed professional in the country. But the truth is, as we push towards those BSNs, the question is have we actually increased the amount of responsibility but turnover that actually did not shift the environment that these elevated professional degree you would think would align to actually value the nurse more in healthcare associated with that degree. So I think there's a debate there to be had, Bob, and I don't think I have a clear answer for it. But there was that movement. There was exactly that perception. And I think one could argue that the state of nursing today is at more of a state of crisis than it was in 2000, where before we did not have that substantial push for increased education across the profession.
Yeah. And we look at the whole experience with COVID and the burnout, all of that. I want to take a second and kind of share with you and our audience as well what we do at the University of Texas, Dallas, when it comes to leadership development. We have a program that's been around for over 25 years, and it's called the Alliance for Physician Leadership. And what we're trying to do is create physician leaders. And these are all doctors. Generally speaking, about 10% of all the physicians are actually physician leaders. And probably another 20% or so, I would put in the category of they're influencers. And then the balance, the other 70%, they're practicing medicine. But what we do there is we try to make the doctors feel comfortable with things that they did not learn in medical school. And most clinicians haven't learned either. And nurses haven't learned either, but they haven't learned things about strategy and negotiation, a lot of the quality issues and things of that nature. And so I have another program at UTD, which is not all physicians. It's physicians, nurses, PAs, administrators, a whole variety of healthcare leaders. But we have total underrepresentation of nurses. And one of my goals in my program is to recruit and get more nurses into our healthcare leadership and management program, because there's just it's an overcoming underrepresentation of nurses. And what nurses do is amazing. Like you said, the role that they perform, and there's no secret there. The impact on quality, the impact on efficiency, innovation, and things like that. It's remarkable. So I'm really trying to get more nurses moving up even beyond that master's in nursing degree, get them up into executive leadership. I know that you're trying to do the same in so many different areas. So let's talk a little bit about innovation, because you've been opening the opportunities for innovation in a pretty big way. Share with us some of the things that you've done along that line, if you would.
Well, Bob, you hit the nail on the head. I mean, from just what you just said, is nursing was never taught anything about the business of healthcare, the strategy, the operations, the finance. So they were taught how to think emphatically, right? We talk in emotional terms as I think, I feel, I believe. And when they talk that way across the bridge, right, to the CFO, which is, I think if we did this differently, we would see better outcomes for patients. And the CFO will look at them and say, that's great, you think that way. Or I really feel that if we had this kind of service, it would drive better outcomes. And it's really great. Your nurse manager will pat you on the shoulder and be like, it's really great you feel that way. It's a nurse. You're sitting there and you're like, what am I saying wrong? Like, I want to help patients. I want to do things. And that was what my experience was as a bedside nurse. I constantly was like, I have this great idea. And if we could try it, I think we could try better outcomes. But all I would get is, Rebecca, that's a great idea. Can you work Saturday? And I'd be like, what am I not saying correctly? So my idea, what happened to me was around hire nurses. As I told you, when we started it out, I had no idea how to make money. It was a great idea. I had tens of thousands of nurses join our platform, but I couldn't get any hospital to ever sign up to use it. Nobody would pay for it. I couldn't figure it out. And I was going to shut down the company. And a friend of mine said, Rebecca, I actually think this is a really great idea that you have. You should come to this hackathon. And that was the event that changed my life. And I know I talk about it in my TED Talk, but showing up at this hackathon where there were no nurses, and I was walking around this room full of physicians, the head of the hospital, CEOs of all the Boston healthcare companies in the country, realizing, oh my gosh, this is where the decision makers are in healthcare. I'm not supposed to be here as a nurse. And when nobody asked me to leave, I felt like I was doing something wrong by joining a team, right? I felt like I was doing something that I wasn't supposed to experience because nurses aren't smart. That's what made me feel like nurses weren't smart enough to be there, because the way we talk about things, nobody would ever hear us. But as I was sitting in that room, and you guys will hear this, that the door opened up and the CEO of my hospital sat down next to me. And the physician starts talking about the problem and the solution fit. And I finally blurred out, this is never going to work. And I was like, you're just creating more work for the nurses. That's not the problem we need solved on the floor. We need this solved. And I remember that the physician said, well, how did I not know that? And the CEO said, well, yeah, how do I not know that that's the problem on the floor? And I said, well, have you asked the nurses? And they both started laughing. So I started laughing. But because I didn't know what was funny until I realized they were laughing because the idea of asking the nurses was funny to them. And that was when, after that experience that everybody found I was there, they started to seek me out. Like, Rebecca, is this a real problem? Not a problem? Everything. That I really felt like, oh my gosh, if nurses were involved in this process, if people really knew the real problems, because the nurses are on the front line and they were given a chance to innovate with all the people with all the power, all the money, all the ability to change things, we could change healthcare. And Bob, that was my next step. I called, people think I joke about this, but I have a tally sheet of calling 167 different nursing schools, asking for there to be a hackathon, until Dr. Hanrahan at Northeastern heard my story, what I just shared with you. And she said, Rebecca, next summer, I'm going to run a summit on innovation and entrepreneurship. Why don't you run a hackathon? And I had 3 little kids under 4, a failing startup. I was working at a community college, and I thought, well, I've been to a hackathon. Sure, I'll run your hackathon. And my life changed. Because at that time, nobody talked about nurses. This was 2015. You look at the research, nobody talked about nurses as innovators or entrepreneurs. You look at research, those words might have been mentioned in the same article, never in the same sentence. So it was considered a fad. The amount of criticism we received, we had no idea if anybody was going to come to that event. And that's when she called me 2 weeks before that event and said, we're sold out. Every major hospital in Boston is sending a team of nurses. Microsoft, J&J, Beth Dickinson are flying in their teams to understand what is this nurse innovation. And she said, Rebecca, I want you to come on and build this program.
So that was Johnson and Johnson got involved?
Back in 2016, this was Northeastern put a stake in the ground to launch the first program around nurse innovation in the country. She asked me to become the director of innovation. They flew in, monitored our program for the next 1 year, from 2016 to 2017, in which nurse innovation became the #1 search term in the nursing world on Google in that year. And then in 2017, they flew us to their headquarters and said, we are pivoting our 15-year campaign of thanking nurses at Johnson & Johnson to nurse innovation is the future of our investment.
Wow. Fasten your seatbelt, Rebecca. You had no idea that rocket was going to launch like that, did you?
You know what? I think to your point, Bob, when you follow your passion and you believe in something for the greater good, when you do it for others and for what you think is the best to change your profession, there are random moments of such brilliant luck or validation after so many no's that I can't tell you, like, no, we would never have seen it coming.
Yeah.
But I often look at J&J and thinking, you were the Goliath that stepped down to elevate the David in that situation. And I don't think nurses would ever have been taken seriously in healthcare innovation had it been for their support.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
You know, right now, we're teaching a course at the University of Texas, Dallas, in our leadership program, and it's called Leading Adaptive Change. And it talks about the difference between something which is complicated versus something that's complex. And the complex adaptive world, that's what nursing and healthcare is. There's so many different problems and pressures and things that take place. And it's not like it's predictable, just like what you just described. That's a great example of some type of change element taking place. And you didn't know it was going to happen. It's kind of like all of a sudden you pull this plug and the whole sand pile comes down. So it's really interesting. But this concept that we talk about, it's necessary. The change is really needed in order for the organization to thrive. And there's a lot of tension in this change. And in order to solve the problem, it calls for a lot of education, and it calls for getting the solution to be bought in by the stakeholders. And what I'd like for you to do is share with us this new commission that you've started. Tell us how it got started and what it's all about, because I think this has got a tremendous amount of potential power behind it. It's called the Commission for Nursing Reimbursement. So update us here if you would.
Bob, it's very kind of you to let me talk about this. So what you may not be aware of is nursing is a cost to healthcare centers. We are the only healthcare professional that is a degreed profession that is a straight cost. And what I mean by that is nursing was rolled into the room right now. I have to step you back into history to understand why this existed. And it has a lot to do with parts of the women's rights movement. So in 1913, the women's suffrage movement had been fighting for women's right to vote at that point for nearly 60 years. And American nurses had stayed out of that battle. But in 1913, the day before Woodrow Wilson's inauguration, they organized the largest women's suffrage movement march in Washington, D.C. in the U.S. history. And for the first time ever, American nurses got involved in that march. It took another 7 years, and in 1920, women got the right to vote. Now, at that time, nursing quickly became the largest economic vehicle for women's financial independence in the history of the world, because in the 1920s, nurses all ran their own independent practices. Private families hired private duty nurses, similar to what they did for private duty physicians to provide care. Hospitals were these deplorable conditions in which only the most destitute would seek care. But as hospitals started to invent surgery, private families hired private duty nurses to come into hospital systems. At that time, they billed separately for their services, but then hospitals started to see care got better, outcomes got better. They started to employ nurses. And in the 1920s, every single hospital bill that was issued had a breakout line for nursing services in which patients were charged for the services that nurses brought to the bedside and provided value for. But hospitals were run by men. Physicians were men, and they started to feel that these women had too much line of sight to the financial model in which existed and their value to healthcare. So as the historians such as Donna Deere said, they were looking for a model that would capture nursing services, but largely keep nurses as far away from the money as possible. So as national insurance started to invent in the 1930s, they turned to hotels, saw maids were rolled into room rates, and they rolled nursing into room rates, hiding their value from plain sight, rising the term handmaiden to the physicians, and leading to our first major nursing shortage in the 1930s, when many nurses walked away from the profession in protest of no longer being able to be valued and paid for their services. And in the course of the last 100 years, although we have made change on reimbursement models, nursing has been the only profession that has been left a cost to healthcare systems, which means that as long as we are a cost, you guys are business professionals, we do not invest costs, we cut costs. So we will consistently staff nurses to the lowest cost denominator, not invest in them. So that's why nurses have no money to go back to these programs we're trying to build. And there is no idea of why we focus on programs that would retain our nurses, because we are simply thought of as a lost cost to systems. So the Commission for Nurse Reimbursement was founded in May 2022, when other nurses came to me and said, Rebecca, we must do this. Our nursing organizations are not going to do it. You need to found this group and lead it. And I thought to myself, oh my goodness, this is a 5 to 10 year commitment if we can change the system. But to me, you guys know this. As business people, if there is not a way to pay for something, there is no business. And until we get nurses out of the room rate and paid for the services in which they bring to healthcare, we will continuously drive this nursing crisis and shortage in the market until we fix the reimbursement model. So that is the Commission for Nurse Reimbursement, Bob.
The change is needed in order to thrive. Without this change, the nursing environment will not thrive. And that really goes back to creating the leadership. If you can't reward people for the value they create, then they can't advance. And
Yes.
you have a staling out of the service level there. It's just incredible. So you started this commission, and is the idea here to petition Congress, petition the Center for Medicare and Medicaid to change the way so that these services can be billed for? They've done this for other types of practices. The list is pretty long, where they now have, rates and charges and things of that nature for other practices. What's the resistance here? What's it take to make this change take place, other than a long time and a dedicated group of people petitioning?
Well, I think there's a lot of resistance. I think it's going to save hospitals. I think it's going to save nursing. I think there's resistance because anytime you start putting value where money goes, people oppose who is actually adding the value, right? So I think there is some question on that. I also think that what it's going to to do, and then to your point, is we've changed this for physical therapists, occupational therapists, respiratory therapists. All of them have billable services except nursing. And we don't ever have any problem hiring any more of those, because when there's increased demand for them, they can bill for those. So they hire more of them. In nursing, it doesn't matter if we have increased demand for nurses, they're going to keep that cost the same, especially with the operating budgets that say that they measure on in nursing and healthcare, because we're the largest cost center to these organizations. We have come up with 6 different models by 2 very different experts in the field, one who sees solutions very differently, because we don't want this shut down. And to your point, going to the Center for Medicare and Medicaid Innovation to say, look at how we could do this effectively. We do not believe that it is going to drive up cost. In fact, we think it's going to lower costs for healthcare, because we have all of these wasted dollars, and they're not going to the one thing that we know that drives better patient outcome, which is nursing care. Right? We're paying for technology and new buildings and all of this stuff that is not actually leading to patients getting better at the bedside. The one correlating factor that people never talk about is we know that for every additional patient that a nurse carries above a safe limit, the increase of mortality within 30 days of admission goes up by 7% of a patient's life. The one direct correlation we know why patients die is not because they didn't have a beautiful building to live in. Not because they didn't have amazing technology next to the bedside. The reason patients worsen and die in healthcare is because they didn't have a nurse there to make sure that they could survive the surgery that they just went through. So that's the idea, Bob. It's to do exactly this. CMMI, Congress, perhaps, even though that would be largely unusual for them to issue such a statement, but that's the idea.
What I think a crucial element here is to get the nurse leaders on the executive teams. And there was a study published in just a couple of years ago, 2021, the Journal of Nursing Administration, and they found that hospitals with higher proportion of nurse leaders on the executive teams, they had lower rates of hospital-acquired infections and patient mortality. I mean, you've got to get them into the executive suite as well. And that will happen. It's happening, but it's not happening fast enough. And another article was the Worldviews of Evidence-Based Nursing. They had several studies, and they said that strong nurse leadership is associated with improved patient safety and quality of care. I mean, that should be obvious, right?
100%.
Yeah.
And to your point, as I said to you earlier, and why I think actually your point is well made, is we weren't ever given those skill sets as nurses. And the reason we don't get elevated to these executive levels is because of the language and the way we speak. People just think, oh, it's so nice that you want to save patients' lives. But this is a business, and you don't know how to operate a business, right? So it's critical. And I say this to nurses time and time again. I said, I wish that I could tell you that becoming a nurse practitioner or getting your MSN in education was going to move the needle significantly for your opportunities and leadership within our healthcare institutions, but it's not. The reality is nurses, nobody's going to learn the business of nursing. They're never going to learn our language, so we have to learn theirs. So the truth is the best path forward for nurse leadership, and though I don't have what I wish I did, is for them to pursue an MBA. Because the best thing that we can do is for them to learn to translate the problems that they're seeing effectively at the bedside into a business case that it resonates with the CEO, the CFO, and the COO. And nobody ever gave us that skill set.
Would you like to see reimbursable services for all of those categories of nurses that you delineated earlier, or would you start with a certain level to get them reimbursed first?
So, Bob, it's interesting that. So I don't know if you're following the current situation at the federal level with regards to a new mandate around nurse-to-patient ratios in long-term care. And in that long-term care program, they actually are looking specifically to reimburse based on RN levels of care within skilled nursing facilities. We could argue, and this is a whole nother topic, that as the for-profitization of the rise of skilled nursing workforce, SNFs or skilled rehabs in this country increased to about now 80% of all long-term care being for-profit, what you saw was a dramatic drop down of the number of hours of care that nurses would be delivering at the bedside. So the federal government is saying, okay, the business of healthcare has gotten to the point of for-profitizations and SNFs that we need to right the rounds, and that all this profit that you're making needs to go to actually mandate a level of nursing at the bedside and care hours. Now, in that model, they went to mandate 2 specific areas. One was RNs and one was CNAs, and they left out LPNs. Now, there's a lot of debate around why LPNs were left out and why CNAs were brought in. But based only, I think, The lack of understanding of why you would not mandate the others is because there has been no funding to actually study the effectiveness of these other degree levels. So that is a gap. We know that bachelor's prepared nurses have been studied when it comes to quality outcomes in comparison to their other professional degrees, but we have not done an extensive way of actually measuring LPN care versus no care in such settings. So I think, to your point, further analysis needs to be done. The easiest place to start is at the RN degree level, because that cuts across all care settings and equal contribution levels, and one that covers both your associate degree nursing and your bachelor's degree nursing based on a level set of an exam that qualifies nursing care at a specific level of deliverability at scale. So I think I would start there. But to be very honest, I would like to see specifically LPNs brought into that program in the future. And likely we would need to be looking at CNAs. However, they are non-degreed, which would be rather unusual to actually create a billable service for just a licensed professional.
So, Rebecca, closing comments here. What message would you like to send out to our audience, especially regarding, the commission? What type of action or support would you like to see happen for the Commission for Nursing Reimbursement?
I think, if anything, I hope if you are listening to this, the one thing that I cannot imagine is a world without nurses. I can't imagine what society would be like. I can't imagine where healthcare would be. Because to me, the one thing that I've always met about nurses is when everybody else is running away, they're running towards that problem. They cross the threshold to take care of people when there was no cure, no treatment, no PPE. By most of the physicians and administrators sat at home, they risked their lives, their families. And I think we need that in this society. I think we need the fabric of nursing to make us better. So we have to stop treating them as they're just simply a commodity that they're not worth investing in, that they're worth fighting for, that this is one of the greatest professions for the American dream, and let's be honest, one of the greatest professions to lead the women's rights movement that we've seen. And so I'm going to ask you to call your congressman. I'm going to ask you to push back and saying, when you show up at a hospital, how many patients do you have? And if that patient load is ridiculous and the nurse is exhausted, you call that hospital CEO and say, you do better for your nurses. And I would ask your legislators, when your emergency room wait times are 19 or 24 hours and there are no nurses and they're looking frazzled there, it's time that if we're going to fix healthcare, we got to save nursing. And it's time that we stop treating them like a cost, treat them equal to every other healthcare profession. And I guarantee that will we see the outcomes that every single tech company says, oh, we're going to save CHF, we're going to treat COPD patients. You want to do that? Just make there be more nurses who want to be by the bedside, because they're the ones who change behavior for patients and save their lives. So please support the commission. It's the commissionfornursereimbursement.com. If you'd like to sign up and follow us, we're 100% grassroots, 100% volunteers, trying to figure a way forward. And if you would like to get involved, we could use your help, because we're building the plane as we fly it in hopes that we can save this profession and make meaningful change in a positive way.
We'll get that link posted at the bottom of the podcast here to make sure that everybody's aware of that. So, Rebecca, all I can say is that you are leading adaptive change, and you're not doing it by yourself. You really are bringing together the people necessary to focus on making this change real. And I applaud you for that. I just think it's incredible. So my personal goal is to get a lot more nurses in my healthcare leadership management program here at the University of Texas, Dallas. And the doctors want it, the PAs want it, we all want it. We see that's a key element to getting that level of attention raised higher and higher to the leadership role. So thank you for everything, Rebecca. We'll be following back up with you. This is exciting. Thank you again. We appreciate it.
Bob, thank you so much for having me on the Business of Healthcare, you guys. As I said before we started, I felt like I was joining quite the legacy of guests. So thank you for having me.
Thanks for listening to the Business of Healthcare podcast. To learn more about the Center for Healthcare Leadership and Management, go to jindal.utdallas.edu/healthcare.